The neurology group has joined or not as yet?
No one.
The neurology group has joined or not as yet? No one.
Mansi, will you open the room now? Because
yes, sir. We'll just.
I think Dr. VP Singh is yet to join. I'll just call him. I think we can go live, sir. I mean, we can start off.
We are now live. We're audible and visible to the audience on Zoom, Facebook, and YouTube.
Sir, Professor Surya, sir, would like to start off?
yes.
Yeah.
Good evening, ladies and gentlemen. We welcome you all to the second session of IAN-NSI Joint Symposium, which has been a collaboration between the two biggest organizations in the field of neurosciences. So this collaboration bring to you the various common problem which we faces in our neurological practice. Predominantly the neurological issue and then added by the neurosurgical stew. The IAN is grateful to NSI to take this initiation on my request to have this symposium at least once in every 3 months. And this symposium today is on eye movements. And to take that forward, I have Professor Sudesh Prabhakar, who is the coordinator from the Indian Academy of Neurology. We also have Dr. Suresh Nair here. So Dr. Prabhakar, kindly take it forward and have this very, very interactive session for our audience.
Thank you, Dr. Surya. And thank you, our neurosurgery team, Dr. VP Singh, Dr. Dwarkanath, that we are conducting this program. I think today's topic is of interest to all of us because out of the whole neurology and neurosurgery, I think the ocular movements are the one which are very difficult to understand. But once you know what is happening, it looks very easy. So I think we would start with the first topic of the day, and that is by Dr. Suresh Nair from Sri Chitra. He will talk on eye movement disorders in surgical conditions seen. As far as the introduction is concerned, the slide, can you show the slide, please?
Mansi, Dr. Lal is in the attendee as the name of Neeraj, so please take him into the
Yes, yes, I have moved. I've moved him, sir.
Dr. Nair, will you?
I can start, no problem.
Yeah.
Okay. So, can I share my screen?
Yes, sir.
Okay. Are you seeing my screen?
Oh, not it, sir.
Not
I'm
yet, sir.
starting the arm.
Are you seeing now?
Ah, yes,
Yes.
sir.
Okay, fine. So let me at the outset, let me thank all of you, especially my friend Dwaraga and Dr. Prabhakar for inviting me to give this lecture on neurosurgical causes of 3, 4, 6 cranial nerve. And also at the beginning, I should bail out by telling that there will be lots of overlap between my lecture and the talk by the next speaker from Chandigarh. And for this, I have got the help of Dr. Madhusudanan. He's the teacher of teachers, all of you know. And he has provided me with 3 clinical vignettes, which I will be showing in the end. So let me start my lecture. So I have no disclosures, and what I will do is, first I will tell about little bit, because nothing is possible without knowing the anatomy of these cranial nerves and how to localize them. And then in the last, I'll bring some clinical vignettes, 3 cases. So relevant anatomy, clinical localization, various pathological causes, and if I get time, I will talk about supranuclear causes of neurosurgical problems. So what are these eye movements are classified as ductions, versions, or vergences. So duction is a movement involving only one eye, that is abduction, adduction, intorsion, extorsion, elevation, depression. While versions are movement involving both eyes, in which eyes move in same direction, which we call conjugate movement. Vergences are eye movements involving both eyes, in which eyes move in the opposite direction. So a little bit about the anatomy of brainstem, because all these nuclei are situated there. We have the brainstem, the internal structure, as we have got the tectum, tegmentum, and the basis. So the part that is dorsal to the ventricle, or the corresponding structure in the midbrain, that is aqueduct, we call it the tectum, which is this green structure. The part ventral to the 4th ventricle or aqueduct is divided into a dorsal part, which is called the tegmentum, and the ventral portion, which is called the basis. The tectum contains cortigeminal plate in the midbrain. It contains the superior medullary velum in the pons and the inferior medullary velum in the medulla oblongata. There are no cranial nerve nuclei or no reticular formation or no tracts in the tectum. How about basis? Basis contains the pyramidal pathway. The pons is the largest because of the presence of pondine nuclei, which receive numerous fibers and project to cerebellum, forming the pondocerebellar pathway. And in the midbrain, the crus cerebri forms the basis. So the tegmentum is most important for us. The tegmentum is divided into 2 layers. The dorsal part of the tegmentum contains all the cranial nerve nuclei, while the ventral part contains a supplementary motor nuclei. And more importantly, is the substantia nigra and red nucleus in the midbrain and the inferior olivary nucleus in the medulla. The tracts cross the rest of the tegmentum, which is surrounded by reticular formation. Brief anatomy of these cranial nerves. Now, how about the 3rd cranial nerve? The 3rd cranial nerve, the nucleus is situated in the periaqueductal gray, and all of us know the anatomy of the 3rd nerve nucleus, which has been described. It's not moving. Let me see. 1 minute. I don't know. 1 minute. I'm stuck. 1 minute. 1 minute. Oh, what is happening? I cannot. Are you hearing me?
Yes, sir. We can hear you, sir.
But my screen, suppose it's not moving now. 1 minute.
You can just unshare it and share it if you want.
Let me go. 1 minute. Okay, I will share again. Okay, 1 minute. I'm sorry for this each 1 minute. Just 1 minute. I am just coming. 1 minute. Are you seeing my screen?
Yeah, no, sir.
You are not seeing, no? Okay. So I have to go out and come. Just bear with me for some time. 1 minute.
No, sir, we are unable to see your screen, sir.
Okay, 1 minute. 1 minute. I am just sorting it out. 1 minute. I have another computer which was there. 1 minute. Let me come from my other computer. 1 minute. Just hold on for 1 minute. I'll be there in no time. 1 minute. I am just there. 1 minute. I am coming. 1 minute. Just 1 minute more. I am just coming. 1 minute. Yeah. Hello. Yeah, you are hearing me.
Yeah, we can hear you, sir, but we cannot see your slides at all.
No, I will come back. I'll come back. Can you see my screen now? Hello.
Yes, sir. Yes, sir. Yes, sir.
You are seeing my screen, no?
Yes, sir. Yes.
Okay.
Please put it on slideshow mode.
Sir, you are muted, sir.
So, Dr. Srinivas, sir, can you hear us?
Actually, Dr. Suresh, I can hear, but sir is having some problems connecting.
Now, can you hear me?
We can hear you, sir, but your slides, you can just put it in full presentation mode, sir.
But now I have put it, you are not seeing that.
No, sir. What I'll do is I'll stop your screen share right now, and
No,
you again.
You are not seeing it.
Screen. Yes, sir. You can again share screen and select the full screen mode when you're sharing.
Yeah. This is for full screen only I put.
Now
Yes,
it is coming, sir.
Yes,
Now
now
it
it
is
is full screen,
Okay,
sir.
Just, I'm very sorry for the hit. Let me quickly come back 1 minute. So I think we left here somewhere in the Techmendum we left. So the anatomy, I was just talking of the anatomy of third nerve. So nucleus is in the periaqueductal gray. We all of us know the nucleus in and around. There are say rostral nucleus of Edinger Westphal and caudal nucleus of levator palpebrae. Other nuclei are all paired nuclei. And what is more important is the most medial of the nuclei is superior rectus. It innervates the contralateral superior rectus muscle. And the Edinger Westphal nucleus, it bilaterally it innervates both the pupils, and also you have the levator palpebrae. It also innervates bilateral. Most important is to know that the most medial of the nucleus, superior rectus, it innervates the contralateral superior rectus. Nucleus, most medial nucleus, again I am repeating, it innervates opposite superior rectus muscle. But what is more important is the decussating fibers. It traverses the contralateral subnucleus, superior rectus subnucleus. So hence a destructive lesion like an infarct or whatever it is, a bleed or whatever it is. If it involves one superior rectus, there is always paralysis of the opposite superior recti. So how to differentiate a nuclear from an infranuclear third nerve palsy? Say nuclear lesion can always cause isolated muscle weakness, but what is more important is if there is a unilateral third nerve palsy with weakness of bilateral superior rectus and also involvement of symmetric bilateral ptosis, it is always characteristic of a nuclear lesion. And also we know this, the rule of Daroff. Rule of Daroff is if suppose somebody has got unilateral third nerve palsy, total third nerve palsy with opposite superior rectus, it is the lesion has to be nuclear. Or if suppose somebody has got bilateral third nerve palsy, and if patient has got a spared levator palpebrae, it is also called characteristic of a nuclear lesion. So one should know that medial rectus has got more than one nucleus. So isolated medial rectus weakness will not come with a nuclear lesion of the third nerve. Third nerve. So nuclear lesion of the third nerve will not produce isolated medial rectus weakness. Second thing is always a nuclear lesion says at the superior rectus supplies medial, superior rectus supplies the opposite side superior rectus muscle. And now coming to the fascicular portion, the fascicular portion is very, very unlike other fascicles of other third nerve or fourth or sixth nerve. The third nerve fascicle do not travel in a single bundle. So what can happen is that fibers are splayed out as given below, hence it may produce affection of some muscle only. So the fascicular lesions which elevate the eyes and lids, they lie laterally. And the pupillary fibers and the inferior rectus, they lie medial, as we have shown. Laterally, we get the most laterally we get the pupillary fibers and inferior rectus, while most medially we get the other fibers. The thing is, the only paresis of levator palpebrae superioris and superior rectus mimicking upper division of the orbit can occur in the fascicle, and similarly or affection may mimic that of the inferior division, that also can occur in the fascicle. So fascicular lesions can produce isolated single muscle involvement or two or three muscle involvement without involving all the other muscles. And then we know that vascular lesion is always associated, most of the time associated with other structures, anatomical structures in the brainstem. Neurologists know all these syndromes and where the lesion is occurring. And after that, it exists into the intrapedunculaar fossa. It courses lateral to the posterior clinoid process, enters the intrapedunculaar system, and then it enters into the cavernous sinus, into the roof of the cavernous sinus. So you have a cisternal portion, which is in the intrapedunculaar fossa. And after that, the third nerve enters into the roof of the oculomotor trigone, right at its center. A third nerve involvement there can produce ptosis, paralysis of all the muscles, accommodation, pupil is dilated. So this is a characteristic feature, the right side affection with ptosis, eyeball is down and out. This is because down and out because of involvement of the inferior rectus, and laterally abducted because of overaction of sixth nerve nucleus. So this is third nerve palsy. So in the subarachnoid space, all of us know that lesions can be due to compression or ischemic neuropathy. This is the classical thing which a neurosurgeon should know. Neurosurgeon should know that aneurysm, a posterior communicating artery aneurysm, this is the supraclinoid portion. Here you are seeing the choroidal artery. This is the posterior communicating artery. The aneurysm can compress the third nerve. So this video, unfortunately, in this thing is not working. My other computer, it was working. You can see the aneurysm here. Third nerve is not seen in this. I will see whether I can run the video in the data. It will produce. The compressive lesion will produce dilatation and under-responsiveness to the pupil. The rule of the pupil in third nerve palsy, when aneurysm compresses the third nerve, sphincter is impaired, iris sphincter is impaired, leading to dilated or sluggishly reacting pupil. And this was described very early, long back in 1958 by Rucker. So why this is getting affected? The superficial parts and pupillary fibers are in the third nerve are located between 12 and 3 o'clock position, as seen in this picture. And that is a place where the third nerve aneurysm can get compressed correctly there. But what is written is absence of an affected pupil in the setting of complete oculomotor palsy almost always excludes the diagnosis of aneurysm. So if there is a total third nerve palsy, if a pupil is intact, it is almost excludes a aneurysm. So but that is not absolutely true. So because pupillary sparing can also occur in internal carotid artery aneurysm. So why pupil can spare in an internal posterior communicating artery aneurysm? Because it is based on the position of the pupiloconstricted fibers within the subarachnoid portion and not on the anatomic relationship between third nerve and PCOM artery aneurysm. So the pupil can get spared because pressure of the lesion being evenly distributed and allowing the relatively pressure resistant pupilomotor fibers to escape injury. That is one of the reasons why pupil can get spared in an aneurysm, in a PCOM artery aneurysm. So, and second is lesion compressing only the inferior portion of the nerve can spare the dorsally situated pupilomotor fibers. So it is not always a rule that pupil has to get involved in PCOM artery aneurysm. So an oculomotor palsy, this is how about ischemic third nerve palsy? An oculomotor palsy with a normal pupillary sphincter and completely palsied extraocular muscles and levator is almost never due to intracranial aneurysm. So a complete third nerve palsy with a spared pupil, usually it is because of ischemic, but we have seen reasons before, so pupils can get spared. So pupil is spared in ischemia as a lesion is confined to the core of the nerve and spares the peripherally situated pupilomotor fiber. Same thing is written here. It can occur with diabetes mellitus. It can occur with other giant cell arthritis, SLE, etc., etc. And usually they have a good prognosis. But one thing one should understand is diabetes mellitus always affects one cranial nerve at a time. It will not affect multiple cranial nerves. So it is, if a patient has got multiple cranial nerve involvement in a diabetes, it is called ophthalmoplegia in a diabetic. You have to hunt for other lesions. Sinister lesion. If more than one cranial nerve is involved, it is very unlikely because of diabetic, but a diabetic patient can develop multiple cranial nerve palsies, then you have to hunt for that at superior orbital fissure, etc., etc. Other lesion is giant cell arthritis. Usually, arthritis always bites the other peripheral peripheral nerve. So most of the time, it may not be the first presentation of cranial nerve palsy. Usually, they have peripheral palsy, foot drop, wrist drop, etc., or joint illness. And other illness which can produce is SLE. So usually it has got a relatively good prognosis. But having told that pupil can be normal in ischemic neuropathy, it is also not correct. Say up to 30% of the patients, they can have a pupillary involvement. This pupil is never blown out pupil. Usually anisocoria is usually 1 millimeter or less. And if it is more than 2 millimeter, one should again exclude an aneurysm. So this is the most important slide for a neurologist athlete. Vasculitis always involve peripheral nerve. That is a foot drop, wrist drop from peroneal nerve, radial nerve, etc., or systemic symptoms before catching cranial nerves. Diabetic ophthalmoplegia is always involve one cranial nerve at a time, never all together. If a diabetic patient develops all these palsies together, it is called ophthalmoplegia in a diabetic, and always exclude sinister illnesses like lymphoma, secondaries, fungal infection, etc., which I will tell later. So this is the end. Once a patient has a third nerve involvement, the pattern of recovery from picoartery aneurysm, the fibers of the medial rectus and levator palpebrae are laterally placed away from a picoartery aneurysm. So those fibers which are laterally placed, they have chances to recover more. So that is why ptosis shows the earliest recovery. Levator palpebrae, medial rectus show rapid recovery. Parasympathetic fibers follow next. So when the recovery occurs, superior rectus is the last one to recover and may not recover totally. So I will skip this. So prognosis, time interval from surgery also matters. If surgery is done within 10 days to 2 weeks, chances of recovery are better. If you prolong surgery after picoartery aneurysm has put the total palsy, very unlikely they recover. Other coexisting illnesses also play a part in the recovery. If they have other microvascular risk factors, normally they recover slowly. So clipping is associated with a higher probability of recovery than coiling. So now again in the cisternal, other aneurysms can catch the third nerve, and that is superior cerebellar, PC aneurysms, not only PICO, other aneurysms rarely. So 70% of the ophthalmoplegia is due to picoartery aneurysms, but rarely it could be from superior cerebellar or basilar aneurysm. So such aneurysms usually can catch inferior division paresis. So there can be trauma, vasculitis, demyelinating illnesses, or a basilar artery aneurysm for a neurosurgeon. It may not catch both the divisions together, only the inferior division, because I told you the divisional thing occurs right from fascicular thing itself. So these things can occur, inferior division, involvement with tumors, maybe pupil sparing, because the insidious tumor growth may spare pressure-resistant pupilomotor fibers. Another thing which can catch the pupil, third nerve is angle herniation, which all of us know. Pupil initially constrict, followed by dilatation. Now third nerve enters into the cavernous sinus, commonest lesion, pituitary adenoma, apoplexy, cavernous carotid aneurysm. We can see this cavernous sinus here with all these cranial nerves in the lateral wall. And here also there is the other ocular motor nerves like fourth and sixth, and the ophthalmic branch of the trigeminal nerve usually gets involved in a cavernous sinus lesion. Combined oculomotor paresis and sympathetic denervation. That is pupil in mid position. Mid position fixed pupil is pathognomonic of cavernous sinus lesion. I will explain why. So it's very important to look for involvement of sympathetics to say whether it is and pupil in mid position, not fully blown out. If it is there with involvement of sympathetic, it is a hallmark of a cavernous sinus lesion. Here again, I am telling compressive lesions can still spare the pupil as they preferentially involve the superior division or the superior aspect of the nerve anterior to the point where the pupilomotor fibers descend in their course to the inferior oblique muscle. So localization in the cavernous sinus, medial lesions in the cavernous sinus, such as a carotid artery aneurysm, affect only the oculomotor nerve, sparing the more laterally placed V1, resulting in painless ophthalmoplegia. Medial lesions in the cavernous sinus, painless ophthalmoplegia. Lesions that begin laterally, present with retroorbital pain, and ophthalmoparesis supervenes only later. So this is a classical example of pituitary tumor. We know the detail what is the layers of the pituitary gland. This is a classification. This is the more commonest tumor we see. So if there is NOS3B extension, that is extension lateral to the tangent drawn to the lateral aspect of the supraclinoid and cavernous carotid. If the tumor extends there, there is more chances of involving this cranial nerve. Otherwise, pituitary tumor usually produces these cranial nerves 3, 4, 6, etc. by apoplexy only. Other lesions in the cavernous sinus, cavernous hemangioma, it is a pure cavernous sinus lesion. It can involve the cranial nerves there. Another lesion is a meningioma, medial sphenoid wing meningioma, or a clinoidal meningioma that can extend into the cavernous sinus. This is a cavernous carotid aneurysm. All of us know aneurysm is there. It can always involve the cranial nerve. Cavernous sinus thrombosis, again meningioma, chondrosarcoma. You have even schwannoma can arise inside a malignant peripheral nerve sheath tumor, nasopharyngeal, very rarely. These tumors, nasopharyngeal tumor and juvenile angiofibroma, can extend into the cavernous sinus, and there can be perineural spread into the cavernous sinus. Even a benign epidermoid can be there. Fungal infection is notorious. It can involve the superior orbital fissure or orbital apex area, extend to the cavernous sinus, may not be seen on a MR imaging, especially mucormycosis, because it is a blood-borne infection, so people can present with multiple cranial nerve palsy. Yet you investigate, you may not see a mass lesion there. You should suspect mucormycosis because it's blood-borne. Other is cavernous sinus thrombosis. You can see carotid cavernous fistula. All these lesions, metastasis can occur. And this is I think Professor Lal will talk on inflammatory lesions, pachymeningitis. All these things can involve the Wegener's granulomatosis. Sarcoidosis is a notorious lesion. So this is a non-infective inflammatory lesion which can involve the cavernous sinus. It extends from cavernous sinus to superior orbital fissure. And superior orbital fissure is just an extension of cavernous sinus. And once it enters orbit, it divides into two divisions. We know where superior division supplies levator palpebrae and superior rectus, while the pupillary fibers, rectus, medial rectus, inferior rectus are all supplied by the inferior division. So localization to the orbit, isolated involvement of muscles innervated by superior or inferior oculomotor branch is the hallmark of if a lesion inside the orbit. And orbital lesions is usually associated with other oculomotor dysfunction, optic neuropathy, proptosis, etc. Even a flaccidity can occur which leads to proptosis because of paralysis of the muscles. So this is a picture which shows it is all a closed space. You have this annulus of Zinn, you have seen all the muscle centers, you can see the optic nerve. So you can get involvement of all this, and this is an extension, a contiguous spectrum. It is orbital apex, superior orbital fissure, and cavernous sinus. All of them can get involved. And all these lesions are there, which I will tell inflammatory lesions, which I think more Dr. Lal will be talking of all this, and fungal infection, notorious for neurosurgeons, especially mucor, and neoplastic. Neurosurgeons' role come here, head and neck tumors, adenoid cystic. So all these things can occur in the superior orbital fissure. And vascular lesion, of course, carotid cavernous aneurysms, fistula, etc. So this is a small word about bilateral third nerve. The central causes is neurologist problem, Whipple's disease, basilar artery occlusion, neurosarcoidosis. Peripheral causes, pituitary apoplexy, our problem, neurosurgeon, aneurysm, cavernous sinus thrombosis, fungal infection, lymphoma, tuberculosis, meningitis. This is very important, cobra and crate bite, especially in India. In Kerala part, it is cobra, I think North India, crate bite. And rarely diabetes and metastatic disease can also produce bilateral third nerve. This is the area of Dr. Lal, pseudo third nerve palsy, myasthenia gravis ophthalmopathy, and chronic progressive external ophthalmoplegia, which we see in mitochondrial illness. Anatomy of the fourth nerve, similar nucleus, fascicular, cisternal, cavernous sinus. It is the only cranial nerve which entirely motor. It is only cranial nerve which arises posteriorly and it winds around and then crosses in the superior medullary vellum, and the rest of the course it goes between superior and posterior cerebral arteries, enters into the cavernous sinus. Very important, it courses posteriorly, crosses in the superior medullary vellum. And this is a good picture. This is how fourth cranial nerve, it comes from the, again at the level of the inferior colliculus, nucleus is there just in front of the aqueduct. Again, it courses like that as opposed to third nerve, which goes anteriorly into the interpeduncular system. Again, between these two cranial nerves into the so it passes through the lateral part of the superior orbital fissure outside the annular tendon. And localization of the fourth nerve, this is classical. You get a head upright hypertropia here. You have this eye is rotated, x-cyclo-rotated, and head tilt to the opposite side. And head tilt, chin tuck to the opposite side, tilt away from the lesion. And this is fourth nerve lesion will produce incompetent hypertropia. That is, it is other side, there is no hypertropia. And this can be, say, this head tilt will become more. Patients usually put the head to the opposite side to avoid this diplopia. And they have S-cyclotropia. This is very important that hypertropic eye is rotated outwards and head tilt eliminates this hypertropia. And this is a classical picture. I will just skip slide. Everybody knows this. And this is another thing which can mimic is skew deviation. It is again a vertical malalignment of the eyes. One eye higher than the other is caused by a pre-nuclear lesion of the brainstem of cerebellum. These patients will also have vertical and torsional diplopia. Pathogenesis, imbalance of otolith inputs into the oculomotor nucleus, that is from the utricular macula to the contralateral interstitial nucleus of Cajal. It can produce skew deviation. It can produce cyclotorsion of both eyes and paradoxic and head tilt. Here, unlike it is similar to fourth nerve, the head tilt is to the opposite side. There is cyclotorsion of both eyes, but this upper hypertrophic eye is encyclotorted, while the eye which is down, which is S-cyclotorted. I will show one picture, and this is anatomical pathway. The lesion is, site of lesion is caudal to the mid-pons, ipsilateral eye is lower. If it is cranial to mid-pons, ipsilateral eye is higher. This is a head tilt. The head tilt is always to the opposite side, but you can see the eye tilt. Eye tilt is trochlear nerve palsy. It is tilted to this side. Here, this is tilt, ocular tilt reaction. The hypertrophic eye is tilted here and hypertrophic eye is tilted outside. So here also same nuclear, fascicular, everything, all lesions are there. Nuclear lesion is still important because this isolated trochlear nuclear lesion is usually associated with ipsilateral ornate or some gaze palsy because the tracks run very close. So the thing is, if a patient has got a superior rectus, superior oblique involvement, look for the opposite eye for sympathetic involvement or gaze palsy to look for whether the lesion is central trochlear nerve palsy. This is what we tell if you enter into the ward, if you see a young child with a eye head tilt like that, say one tumor which is medulloblastoma. Medulloblastoma is a beautiful, good-looking children. You enter into the ward, you see a young child with posterior fossa tumor with a head tilt. You know this is because of trochlear nerve involvement in the superior medullary vellum. So lesions in the subarachnoid space, similar, it can be isolated trochlear or the other things are very near. Superior cerebellar peduncle, they will have dysmetria. They can have, if cerebral peduncle is getting compressed, they can have contralateral hemiparesis. These lesions as the third nerve can enter into the cavernous sinus, same ophthalmoplegia, other cranial nerves can get involved. And they can have other features of this is same thing in the orbit also. They can have mechanical obstruction, other oculomotor palsy, similar to third nerve. Anatomy of the sixth cranial nerve, again, this arises at the floor of the fourth ventricle. You can see where the nucleus is in the floor of the fourth ventricle. And we all know that the seventh nerve winds around the sixth nerve. And this is it has got a cisternal portion. It has got a vascular portion, cisternal portion. Then it enters into the inferior petrosal sinus. So this is the, after it exits from the brainstem at the pondomedullary sulcus. So it's the sixth nerve is arising at the this is the pondomedullary sulcus. It arises ventrally, just above the vertebrobasilar junction. Vertebrobasilar junction 5 millimeter above. In the pondomedullary sulcus, it arises. So it has so it then goes towards the inferior petrosal sinus. Inferior, it has a cisternal segment, then it has a petrosal segment, then a cavernous segment. I will just tell you this. Petrosal segment, it goes in the inferior petrosal sinus first, then it goes through the Gulfar segment, which is a superior part, which is a confluence of sinuses of inferior, superior, basilar and cavernous sinus, goes underneath the Gruber's ligament to enter into the cavernous sinus. In the cavernous sinus, here it is going lateral to the vertical segment of the cavernous carotid, and then further forward it is infracarotid. So this is again a good picture showing the sixth nerve entering the in the venous confluence, going under the Gruber's ligament or sphenopetrosal ligament, which is actually a thickened inferior band of the posterior petroclinal ligament, and then enters into the cavernous sinus. And this is very important. There is another fibrous tissue which anchors the carotid to the Meckel's cave area. It can mimic like a Gruber's ligament. Why this is important? Only after it pierces this, it becomes a cavernous segment. And the sympathetic fibers from the carotid, they move to the sixth nerve at this point. Again a picture of Dorello's canal.
Dr. Suresh, please, you have to summarize because the time is.
I will skip. Okay. This is, it has got a brainstem syndrome. It can have subarachnoid space, petrous apex, cavernous syndrome, orbital syndrome. So it can have elevated intracranial pressure. It's a similar localization. I will skip because all of us know in the brainstem, abducens, fascicle, subarachnoid space, elevated pressure. And the petrous apex syndrome with neurologist Gardner syndrome, and in the cavernous sinus superior orbital pressure, all of us know. This is how we pick up a sixth nerve lesion, and these are the various pathologies which can cause this sixth nerve involvement in the nucleus, fascicle, subarachnoid space, cavernous sinus. And this is what everybody should know. Isolated sixth nerve paralysis, always look for hornets. And isolated sixth with 12th nerve, it is a lesion along the clivus. All these surgical lesions, chondroma, chondrosarcoma, isolated sixth with 12th nerve involvement. So this is third nerve, it is vasculopathic aneurysm, fourth congenital trauma, and all these mimicates. These are the 6 mimicates which I think Lal will be talking. Diplopia can occur even without a cranial nerve deficit. Probably Dr. Lal will talk on hemiplate slide. And this is a case which I will quickly finish. This is a lady who presented with the vertigo, and so this patient had bilateral lateral rectus weakness with acquired pendular nystagmus, had this finding bleed in the midbrain pons, and it was a cavernoma, and DSA was normal. Years later, patient presented with follow-up MRI shows hypertrophy with hyperindent signals in the inferior olivary nucleus area. You can see here inferior olivary nucleus area. So what is the diagnosis? This is an old case of cavernoma with bleed with evidence of hypertrophic olivary nuclear degeneration. Delayed scan, you know what is Gilden-Mollaret triangle, and I don't have to teach. This can be, it's a rare condition. This can be caused by tumors, especially after resection of posterior fossa intracranial tumors. And these patients will show this classical thing, and because of damage to central tegmental tract, and common causes are hemorrhage, vascular malformations for neurosis, head injury, etc., etc. Our patient did not have the classical palatal or ocular myoclonus, and DD includes say astrocytoma, lymphoma, metastasis, etc. So it is important for radiologists to distinguish this type of hypertrophy from tumor recurrent. And this is a brainstem cavernoma. Another lady presented with severe headache. Patient didn't have anything, blurring of vision, and this is the patient's photograph. And patient had vertical diplopia, is becoming worse on turning the side. So false image disappeared on closure of the left eye. So this patient had vertical diplopia, hypertrophy of the right eye. False image was disappeared. So we know it is a left inferior rectus. And we know that isolated single muscle involvement can occur in the fascicular portion. And this we have discussed already. And I will skip all this. And the fascicular lesion, MRI of the brain was reported normal. And then the CT scan shows blood in the perimesencephalic cister. And the CT angiogram was normal. And this patient, second day, patient was okay, developed headache. Then later, fourth day, developed ptosis. So what is my repeat MRI was normal, but there was some enhancement of the third nerve here. So why this enhancement occur? And what is the cause of this delayed third nerve palsy, which improved in this patient? So this is also a case which both neurologists and neurosurgeons show. Perimesencephalic SH is a distinct part of SH. Around the midbrain, 95% will have normal DSA. Cause is thought to be venous bleed, and neurosurgeons should be aware of other causes also. And this, I think I will skip. This is a patient who presented with the primary optic orbital apex syndrome. A patient with cranial nerve palsy with the loss of vision. So it could be a superior orbital fissure syndrome. With visual loss, it becomes an orbital apex. Orbital apex.
Sir, we are running out of time, sir. We have already finished 45 minutes.
Just over. So one should think of various pathologies and etiology different. I think this is one slide which probably Professor Lal will talk of all these lesions. We have neurosurgeons have these inflammatory lesions. I will just skip everything and go to conclude my talk. So sarcoidosis, all tolosohan, the infectious mucormycosis is a great thing. Probably my next speaker will talk. And last one slide I will show, and I will this patient, I will skip this patient. I think I have run out of time. No improvement. 1 minute. Okay. Okay. So this is the conclusion: is evaluation of patients with 3, 4, 6 palsies can be challenging, as etiology is extensive. And presentation could be acute, subacute, chronic, could be presenting feature of both benign and malignant lesions. It can involve other cranial nerves as well, which could be sequential, discrete, uni or bilateral, painless, painful. Anatomical localization could be anywhere. And this vasculitis is a mimicker, diabetic ophthalmoplegia, always you think. And tumor is one of the most common etiological factor concerning a neurosurgeon. Should be aware that tumors can involve cranial nerves not only by local compression or direct infiltration, but also by paraneoplastic process. And differential diagnosis is extensive, and histopathological diagnosis is a key factor. So diagnosis is not the end, but the beginning of practice. Thank you.
Thank you, Dr. Nair. It was an exhaustive and excellent talk. I think we'll invite Professor Vivek Lal for the second part of the talk, which is the eye movement disorders seen in medical disorders. Dr. Lal is professor and head of neurology department Chandigarh, and also the director of the institute. He is former Dean of Baba Free University of Health Sciences, Punjab, chairman of Neuro-Ophthalmology subsection of the Indian Academy of Neurology. He was invited chair and faculty of teaching course and scientific session of Neuro-Ophthalmology in the World Congress in Kyoto and in Rome, Italy. He was a visiting guest faculty at the University of Oxford, and he was a visiting neuro-ophthalmologist at the University of Addis Ababa, Ethiopia. He has done pioneer work in the identification and discovery of ophthalmoplegic migraine in India for the first time. He has many publications, more than 200. I think I'll not come in between Dr. Lal and the audience. Dr. Lal, please.
So good afternoon, everyone. Am I audible?
Yes.
Yes, sir. You
So
are.
are my slides clear?
Yes, sir.
Yes.
So good afternoon, everyone, and thank you so much, sir, for allowing me into this session of yours. I just basically try and concentrate on eye movement disorders and medical conditions. As we all are all aware, there are numerous medical conditions which are synonymous with very exquisite eye movement disorders. So we're going to discuss those medical conditions, and we're going to discuss how those eye movement disorders are there in those conditions. So we have the afferent and efferent visual pathways. I don't have to tell you much about the afferent and efferent visual pathway. That's done. What is important for us to remember is, it's an important fact that both the afferent and the efferent visual pathways are accurate to 1/1,000,000th of a millimeter. When it comes to foveation, your vision will, all the objects of desire and interest will hit the fovea, not right, not left, but on the fovea. And that is the purpose of all eye movements. The purpose of all eye movements is to keep the object of interest on fovea, on the fovea. And what are the different types of eye movements? There are 6 types of eye movements. We all know that. Saccades are the fastest movements known to man. They are the fastest movements in the universe known to man. And they are impeccably perfect. Impeccably perfect. There is no wishy-washy about saccades. It's just that if you have to see something, if you're a normal person, your eye will stop at that person of interest or object of interest. You have smooth pursuit, you have optokinetic nystagmus. We all know what optokinetic movements. And then you have vergence, you have vestibular ocular movements, and you have finally fixation, which helps us fix the gaze on the fovea. So basically, there are abnormal and normal movements. We will discuss them one by one. What are the abnormal eye movements? We're going to talk about them. We're going to talk about nystagmus. We are going to talk about, gaze abnormalities, and we're going to talk about other type of abnormalities, anomalies that we get to see in unconscious patients. Now, the single commonest, we'll begin with nystagmus. I said the topic is eye movements in medical conditions. The single commonest movement, eye movement, abnormal or normal, that you get to see is horizontal gaze evoked nystagmus, which is often symmetrical. I repeat, horizontal gaze evoked nystagmus, more often on extreme gaze, right, is the single commonest movement that you get to see amongst eye movement disorders. You can have that with dilantin, plain dilantin. With dilantin toxicity, it'll be an upbeat nystagmus. If you're taking simple dilantin, it's going to be a little nystagmus. Carbamazepine, again, gaze evoked, horizontal nystagmus. Dilantin, gaze evoked, horizontal nystagmus. Little bit of alcohol, gaze evoked, horizontal nystagmus. More than necessary alcohol, upbeat nystagmus or downbeat nystagmus. And psychotropics also produce this kind of nystagmus. Not only is this nystagmus pathological, this can also be physiological, in the sense that if you have been subjecting your gaze to a non-stop, input. Now, let me give you an example. You are traveling on a highway, and you've been traveling for say 6 to 8 hours non-stop, and you've not slept in between, but you've been observing everything on the way intently. You may get a gaze evoked nystagmus bilaterally when after 6 to 8 hours. So that's physiological nystagmus. The important thing to remember is this is always symmetrical. It is not asymmetrical. The other important nystagmus is upbeat nystagmus. So that was about horizontal gaze evoked nystagmus. Now we come to upbeat nystagmus, vertical, up and down. So we had that horizontal nystagmus. Now we're going up. The upbeat nystagmus does not have a specific localization. As the word indicates, it is maximal on up gaze, and the fast direction is on moving up, right? When you look in grade 3, you will also have an upbeat nystagmus looking down with a fast component up. But by and large, upbeat nystagmus will be maximum when you are looking up. I repeat, when you are looking up. But this does not have a definite localization in the sense that the localization for upbeat nystagmus is anywhere from the top of the diencephalon till the bottom of the medulla. So much so that you can also get an upbeat nystagmus when you have got a lesion in the upper cervical cord. So that lacks localization. Now, what are the conditions which are associated with upbeat nystagmus? Wernicke's encephalopathy, excessive smoking, thallium toxicity, organophosphorus poisoning. These are some of the conditions where you can get upbeat nystagmus. Even lithium toxicity can produce an upbeat nystagmus. It can occur in lesions of the pons. It can occur in lesions of the thalamus. It can occur in lesions of the medulla. Again, I repeat, upbeat nystagmus is never physiological. It is always pathological. Upbeat nystagmus will be symmetrical. The amplitude increases on up gaze. Now have a look at this patient whom we had in our ward. Notice very carefully that this patient came to us with a brainstem syndrome, diplopia, ataxia, and stiffness and weakness of all 4 limbs. So when you have this combination of diplopia, ataxia, and stiffness and weakness of both upper and lower limbs with tonic spasms, your immediate concentration is on the brainstem. Have a look at this eye movement now. This patient has bilateral ptosis. You're seeing the bilateral ptosis. This is symmetrical, and have a look at the eye movements. This is what upbeat nystagmus is. There is a fast component up. It's a fast upbeat nystagmus, and there's a slow component down, right? There it is. And it is maximal on looking up. I hope I have made the point. This is a patient who had aquaporin antibody positive neuromyelitis optica. Notice that this patient did not have visual loss. This patient had an NMO syndrome without visual loss, and there was a lesion in the brainstem. She came to us with a subacute onset illness characterized by ataxia, diplopia, and tonic spasms. This patient also had a gaze-evoked lateral nystagmus, horizontal lateral nystagmus with a rotatory component. But the hallmark was, as I will show you again, was an upbeat nystagmus. I want you to concentrate on the upbeat nystagmus. Have a look at the nystagmus when the patient looks up. There it is. So it accentuates when the patient is looking up. That is upbeat nystagmus. And this patient had an NMO positive syndrome without visual loss. In contrast, this is another patient, again an NMO syndrome, which was MOG positive. This patient had paraparesis and visual loss, but had come with an ocular flutter. You seeing the flutter? That's an ocular flutter. I'm showing both simultaneously. That was NMO without visual loss. This is MOG with visual loss and an ocular flutter, right? This patient had a cerebellar syndrome in addition to opticospinal syndrome. So basically, an ocular flutter is a saccadic intrusion without a definite interval. Now we come to downbeat nystagmus. We've discussed gaze-evoked horizontal nystagmus. We have discussed upbeat nystagmus. I have mentioned that upbeat nystagmus does not have a localization. In contrast, downbeat nystagmus has a definite localization. There is an important thing about downbeat nystagmus besides the fact that it is maximal on looking down, as happens in upbeat nystagmus, which is maximal looking up. Downbeat nystagmus also has a unique sign that it is increased when you look down and out. So instead of looking down, you tell the patient to look down and out, right? There it is. Have a look at this patient with the downbeat nystagmus and just see what happens to the eye when the eye looks down and out. This patient had an Arnold-Chiari malformation. Notice the patient has bilateral ptosis also. And now look at the nystagmus. When the patient is looking down and out, it gets accentuated. I hope I'm clear, right? There it is, right? This is downbeat nystagmus. But when you tell the patient, this patient already had a lateral gaze evoked nystagmus. But when you tell the patient to look down, straight down, the accentuation is not so exquisite. It's more pronounced when the patient looks down and out. This is called Deroff sign. Downbeat nystagmus, in my opinion, in my 30 years experience as a neurologist, is almost always due to a CV junction anomaly. I have not seen a downbeat nystagmus in any other lesion other than a CV junction anomaly. You might have, you get a downbeat nystagmus with some drugs, but of the 100 downbeat nystagmus cases I've seen, 95 have had an Arnold-Chiari malformation or a CV junction anomaly. Now, this is a question which often people ask me. Does B12 deficiency give rise to some kind of a nystagmus? I'm just showing this, slide for you to keep in mind that there is literature that B12 deficiency does produce some eye movement disorders. But I am not particularly convinced of a B12 deficiency giving rise to eye movement disorders, especially when you have isolated B12 deficiency. If you're having B12 deficiency because of alcoholism, obviously you're going to have eye movement disorders in addition to B12 deficiency. But nutritional B12 deficiency alone, I probably would not say produces an eye movement disorder. But I'm showing you this slide so that you keep this in mind. Should the need arise for you look for a cause which is not obvious, do get the B12 levels done. Then finally, you have seesaw nystagmus, again, a kind of vertical nystagmus. We all know what is seesaw nystagmus. That's seesaw. Like a seesaw, one eye goes up, the other eye comes down, right? One eye goes up, the other eye comes down. Now, this is a patient who's got a seesaw nystagmus. Have a look at this. This patient had one eye is going up. One eye is intorting going up. The other one is extorting going down. I hope I'm clear. I'll show it again to you. This is a fast seesaw nystagmus. This patient had a pituitary adenoma. I'll show it again so that there it is. You're seeing the jiggling of the eyes, one going up, the other one coming down, right? In a typical seesaw fashion. It's more pronounced here in this patient who had a pineal loma. There it is. There. You can't see a better demonstration of seesaw nystagmus than is evident in these. I mean, obviously, these cases have been from our ward only. Astha has given me these slides. And she's my right hand in neuro-ophthalmology. She does almost all the work that I show you. I to be very honest, and I give her and my team all credit for giving me these slides at 24 hours interval. In fact, I just came back from a official visit just 1 hour ago, and this is the first time I'm seeing the slides actually. But they're so beautiful that I don't need to kind of, rehearse them. So let me show this to you again. So beautiful slides. Look at that. Look at the seesaw again. One eye goes up. Now look at the next movement. There it is. That's typical seesaw nystagmus. It's seen in paracellular lesions. It is seen in cellular lesions and in, in case of pineal tumors, right? There it is. Slow there, right? Now, what is Brunn's nystagmus? I'm sure all of you know what is. It's basically a surgical nystagmus, fast component and a coarse component. Meaning thereby, when the eye looks in one direction, there is a fast component. When the eye looks in the direction of the lesion, there is a coarse component. That's a Brunn's nystagmus, classically seen in cerebellar lesions. The coarse component is on the side of the lesion, right? Let's have a look at this. There it is. You saw that? Let me show that to you again. So beautifully demonstrated. Now I'm showing it to you again. Sorry. See, look at the eye movement on the right side. That's a fast component. Okay. Now when the patient looks toward the left, there's a coarse component, and the lesion is there in the left cerebellum. See, left CP angle. So Bruns nystagmus classically was described by Cushing in a CP angle tumor. One side fine, other side coarse. What is pendulum nystagmus? There is no fast or slow component. Pendulum nystagmus is a nystagmus where you're getting to see the movement across the visual axis without any fast or slow component like a pendulum. That's a fast pendulum nystagmus, but notice that there is no fast or slow component at all. Now, this is not, this is congenital pendular nystagmus. Why is this not opsoclonus? This is not opsoclonus because this is unidimensional. This is across one plane. The eyes are not jumping across planes. It's horizontal and across one plane. Let's have a look again. There it is. You seeing this? Eye movements, eyes up and, to and fro like a pendulum without any fast or slow component. This is a congenital pendulum nystagmus. You get acquired pendulum nystagmus when you have complete visual loss. In that case, the eyes are looking for a target and then you get acquired pendulum nystagmus. Sometimes you get convergent, divergent pendulum nystagmus. This is a patient who had a brainstem stroke and who had convergent divergent. Look at that. I think he was a chronic alcoholic and he had this problem. Convergent, divergent pendulum nystagmus, right? This is a unique case. I'm showing you all that I'm showing you is from my department. I'm not showing you what I've read in books. That's how happy we are to be in PGI. This is a case which has been accepted for publication, a patient of Whipple's disease with the oculomasticatory myorrhythmia, which means look at the eye movements, look at the facial movements. There is a synchrony between the two. I repeat, concentrate both on the eyes and the face. I'll show it again. This went very fast. Look at the facial movement here and look at the eye movements. It's come out subtly, but it is obvious and it is well seen if you can concentrate. This case was provided to me by Neeraj Balani, who's the first author of this paper, which has been published, which is accepted for publication in JNO. I missed the diagnosis of Whipple's in this case. I thought it is some kind of a subcortical myoclonus, but they on their own did everything and they presented me with what was clearly a case of Whipple's disease. This patient had a myositis to begin with. Joint pains, myositis. So I thought it's some collagen vascular disease. This patient's PET scan was showing intense FDG uptake. So I thought probably you're looking at a vasculitis of the brainstem or a primary CNS lymphoma of the brainstem. But I actually, to be honest, had missed this beautiful eye sign, something unique. This does not occur in any other eye movement disorder. Look at the eyes. There is a convergence, divergence nystagmus, and look at the face. You seeing that? There is a clear-cut synchrony between the two. So this is now published. Thank you so much, Neeraj, for giving this to me. And we now come to gaze.
Sir, if you don't mind, can you just show that again, sir? It's a very interesting video.
I will show it to you again and again. Time is the only limiting factor. Just see.
Wonderful.
Look at the eye movement. Look at the face. Concentrate on both. There. You are seeing convergence, divergence. I'll show it to you again.
So just a minute before you show it, he has his eye movements also. The lids are also moving.
Yes, they are moving. That is what made me think of a sub brainstem myoclonus. That is, everything is moving in the eyes and everything is moving in the lips. You seeing that?
Yes.
I hope I'm clear. That's why it's called a ocular masticatory myoarrhythmia. This is classical of Whipple's, and I missed it. That's it. Big surgeons make big mistakes, so there is no reason if I right? I missed it, and these guys picked it up. And they presented me with this, and I said, yes, that's right. And of course, the biopsy of Whipple's, then it was established, a gut biopsy, and we got the organisms, positive organisms. And in fact, I don't have the follow-up. On follow-up, the patient recovered completely, complete recovery, complete resolution. We come to gaze. The gaze disorders, saccades, we all know. Important thing about saccades is they are the most perfect movement disorder, movements known to man. And you define a saccade by its amplitude, speed, what kind of saccades they are, which direction, conjugacy, accuracy, things like that. We all know that saccades are controlled by the frontal eye fields, the basal ganglia, and the pons. And that horizontal saccades have a center in the pons, and vertical saccades have a center in the, in the middle, in the midbrain. So what is important to remember is, besides saccades, there are two types of saccades, basically reflexive and voluntary. Voluntary saccades, you generate a saccade. Reflexive is suddenly when you're walking on the road and you drive, you're not walking, you say you're driving a car and a stupid cyclist suddenly comes in front of you, which is so common in India. And everyone will blame the car guy if that cyclist gets banged, right? You have a reflexive saccade in that direction. So a reflexive saccade is always in response to a stimulus. That's important. And reflexive saccades are lost before voluntary saccades in Huntington's chorea. That's the importance of saccade. Other thing about saccades is, what is important about saccades, and please remember that, is they always will be symmetrical saccades. You hardly get to see a latent period in saccades on the bedside. So if you are eliciting a saccade and you can appreciate a latent period, then it is, even if the patient is able to reach the target, please exclude myasthenia gravis. It is very well known that myasthenia gravis is a big mimicker of almost every neuro-ophthalmological disorder. So when you are able to see a patient who is able to reach the target when you're examining the saccades, but is slow in generation, please exclude myasthenia gravis if there are no other cerebellar signs, etc., etc. Then you have smooth pursuit, and then you have other eye movements which are controlled by distinct symptoms. The occipital lobe has a major role to play. The parietal lobe has a major role to play in these saccades. Let's have a look at the eye movements in different types of movement disorders, extrapyramidal disorders. Remember, for practical purposes, Parkinson's disease does not have any eye movement disorder. I repeat, for practical purposes, on the bedside, 99 or maybe 95 out of 100 on the bedside. I repeat, on the bedside. I'm not talking of the laboratory. On the bedside, 95 out of 100 patients of Parkinson's disease will not have any eye movement abnormality. The only thing which you can get to see occasionally is limitation of up gaze. Up gaze. This is clear-cut Parkinson's. Now see this. This is clear-cut Parkinson's, right? Okay, let me show that to you again, please. Let me show that here. Right, that's unilateral Parkinson's, hemi-Parkinson's as we all call it. One side trembling, and now have a look at the eye movements in this case. So there is limitation of up gaze, but the down gaze is intact. In PSP, it's the down gaze which goes, but here the up gaze is gone. The MRI was normal. So this is the only abnormality that you get to see in Parkinson's at times. So then I talked about, slow saccades occasionally in Parkinson's, but no, that don't happen. Eye movements classically are spared in Parkinson's disease. If you are having slow saccades in a patient which you think is Parkinson's, it's extrapyramidal plus syndrome. You have progressive supranuclear palsy with a host of eye movement disorders. I'm going to show them to you. Have a look at this patient. Concentrate on the down gaze. Concentrate on the down gaze. The horizontal gaze is intact. Look at the upward gaze is intact and the patient cannot look down. Rather, the patient looks, when I tell the patient to look down, the patient looks sideways. But the vestibular ocular reflex is intact. I hope I'm clear. So the VOR is intact, rather brisker than usual. But the down gaze is not gone. I'll show it to you again. See that again. Horizontal gaze normal. Upward gaze normal. Yes, that's it. Down gaze, there it is. She stops there. She goes back up, right? Then we do the VOR. The VOR is classically brisker than normal, meaning thereby that this is a supranuclear gaze disorder. It's not nuclear, it's a supranuclear gaze disorder. There it is, right? So this is initial PSP. In advanced PSP, you have complete freezing of the eyes. And Huntington's disease, have a look at Huntington's. This is a patient who's got Huntington's. What happens to the eye movements? Saccades are absent. Pursuit is the last to go. Saccades are the first to go. Now look at the pursuits. They are there, they are present. But have a look at the saccades again. I'll show it to you again. See that? Concentrate on the saccades. See, he's got chorea. We are trying to make him generate saccades. He cannot. He's thrusting his head in the opposite direction and he's creating a mechanical saccade because he's got complete saccadic agenesis while pursuits are relatively spare, right? As the disease progresses, this is what happens. Complete freezing of saccades. There is no saccade left and we're asking him to look right and left. He's just thrusting his head in all four directions. Right, left, up, down. Because the saccades have gone. But now the pursuit has also gone in this case. Then you have scar disorders. Unique about scar is the Vadia-Swamy syndrome. I always take the name of Vadia-Swamy because I'm a proud Indian. And when an Indian does something good, I love acknowledging it. So this is a unique syndrome. Now it's called SCAR2. Is it called SCAR2? I think it's called SCAR2. Yes, have a look at this. So this patient had a cerebellar, cerebellar disorder. Pursuits are slow, but now have a look at the saccades. There is no saccade, the saccadic agenesis. Just see, when you tell the patient to look towards the left, he's not able to, he can't generate a saccade. He's looking into your eyes, we are asking him to look towards the left. We are asking him to look towards the right, again, he can't generate a saccade. And he's got a SCAR2 anomaly. Then we have autoimmune disorders with eye movements. This is a medical talk. So this is what I mean by autoimmune disorders. Lot of autoimmune encephalitis we get to see. Now concentrate on this 15-year-old girl. Am I audible to you? Am I audible to you? Am I audible, please?
Yes, sir.
Yes.
Yes.
Now concentrate on this 15-year-old girl who had a 7-day history of fever, behavioral disturbances, myoclonic jerks, dystonia, and perioral dyskinesias, right? There she is. We saw her in this state. She's got an oculogyric crisis. Her eyes are just looking up, right? And she's got dystonia of the left limb. She had dystonia the rest of the body also. She was not able to move her eyes in any direction because she had fixed gaze upstairs. You know, this is a typical oculogyric crisis. All this happening within a span of just 7 days. Myoclonic jerks, behavioral disturbances, perioral dyskinesias. I think she was NMDA positive. Initially, we thought it might be SSP, but then she was NMDA positive. Let's have a look at this patient again. There we see. Why I'm showing you this patient is we plexed her, we gave her immunosuppressants, and this is what happens on follow-up. She's reading her geography textbook. It's the same patient. It's not something which is in a Hindi movie, you have someone else faking as someone else. This is the same patient who is reading her geography textbook to us. There it is, these are the kind of miraculous recoveries that you can have if you properly treat a patient of autoimmune encephalitis. And autoimmune encephalitis is an autoimmune insult. So you need to bombard them with immunosuppressants. In my opinion, the most powerful immunosuppressant is plasmapheresis. If you have it, give it. In fact, I prefer plasmapheresis over IVIG. That's my first port of call. I would any day go for plasmapheresis. I insist on plasmapheresis, and the result is there for you to see, right? Now, in contrast to the previous patient who had got an oculogyric crisis, We once got a call to see another patient of ocular crisis, which was felt to be drug induced. Now have a look at this patient. There it is. When I saw this patient on call, I kind of felt that there is a labellian difference. So I asked her to close her eyes. She was able to close her eyes, right? So when I saw this, remember in ocular crisis, the eyes are not in voluntary control. So when she was able to close her eyes, you know that this is not a drug-induced ocular crisis, but a psychogenic ocular crisis. I hope I'm clear. So a psychogenic ocular crisis is under voluntary control, as is being seen in this patient, whereas a definite organic ocular crisis is not under voluntary control. I hope I'm clear, right? This is another patient. This late girl had an ovarian teratoma, and now she's doing her MBBS in Manipal. So when she came, this is how she was. Notice the ocular flutter. Again, a 7 days history. I think she had a 7 or 8 days history. Jerky movements, subacute onset, cerebellar ataxia, gait disorder, right? And we found this ocular flutter. She had bilateral ptosis. Look at the gait. She had a stimulus sensitive myoclonus. You see that? See that? There. Right? You seeing that? She's having a myoclonus respond to sound, and she was not even able to walk in a straight line. She had severe cerebellar ataxia, and she was not able to hold a pen also with her hands. You seeing the ataxia, the impaired tandem gait, right? So she turned out to be having an ovarian teratoma, and we took out the teratoma. I repeat, we took out the teratoma and we gave her plasmapheresis also. And this is what happened on follow-up. Look at the eye movements now. There is no flutter. The eyes are perfectly coherent. If you want, I can show this to you again so that you can compare both the eyes simultaneously. There. You're seeing the flutter here at presentation, and this is on follow-up. And here is the gait, perfectly normal, right? Let me concentrate on the eye movements. I want you to see the eye movements. Look at that. You're seeing the flutter and the eye movements on follow-up. And then when she gave us a beautiful card, thank you, doctor. This is the same girl who, when she came, could not hold a pen with her hand. And it's impeccably, written. Thank you, doctor. Sujit, her handwriting is better than yours, that's for sure, right? So there it is. She's now doing her MBBS in Manipal. Let me move on. We have some PSP mimics. I think you tell me where to stop, please. I've got so many good slides to show that I don't stop until I'm not told to stop. So this is a PSP mimic.
The problem is you have such good slides, we don't feel like making you stop.
No, you have to tell me to stop. Now, this is a patient who came with a 4 weeks history. This is a 45-year-old lady who came with a 4 weeks history of an extrapyramidal syndrome. She came with complete extrapyramidal syndrome characterized by frozen eye movements and an inability to walk because of severe rigidity. So it was just a 4 weeks history. The attendants were certain. Now have a look at this. She had a vacant stare. She had involuntary movements, typical hand movements, which you get to see. Let me show you the gait. She was not able to walk properly. So she was not able to walk without support because of her severe rigidity, and she had hand movement. You've seen the hand movements. The hand movements, there was a tremor, and she had this two-paced posture, a typical Parkinsonian posture, all this within a span of 4 weeks. And this is complete frozen, eyes. She didn't have any up gaze. She didn't have any down gaze. See that when we ask her to look up or down, she can't do that. She's got complete saccadic agenesis. All this happening within a span of just 4 weeks. And believe it or not, my team immediately said, sir, this is paraneoplastic. This cannot be anything else. Appropriately so. We thought in terms of a paraneoplastic disorder. We got all the investigations done. Normal. Then we got the PET scan done. There was one lymph node which was FDG evade uptake, which is showing FDG evade uptake. And when we biopsied that, metastatic breast carcinoma. So that is how important it is to be clinically vigilant. So within a span of just 4 weeks, she became a statue and she had frozen eye movements. She was almost let off without a diagnosis until the PET report came, FDG, avid uptake, SUV mass, and that showed a metastatic breast carcinoma. So that's about Niemann-Pick disease. I think I'll just show you one slide about Niemann-Pick. Niemann-Pick, I think it's the upward gaze which goes, a vertical gaze which goes. The horizontal gaze is normal. This was, I think, published in Green Journal of Neurology by I'm forgetting her name now. What's her name? Really, what's happened to me after taking over? So this was published in the Green Journal of Neurology. Notice that the horizontal gaze is intact. Horizontal gaze is intact and the vertical is gone. Right? Down. Look at that. She can't look down. This is another patient now. This is Gaucher's disease, proven Gaucher's bone marrow biopsy. He came with what I thought was SSP, but turned out to be having a, look at the myoclonic jerks. Look at the eye movements. Down, up, down, up, down, down. So he's got horizontal gaze disorder, and these were the Gaucher cells which you get to see on bone marrow biopsy. So one last slide. Have a look at this. There is no differential diagnosis in this case. This was Salmonella typhi positive. This is not falciparum positive. This is Salmonella typhi positive. Initially, they thought it is falciparum. She was falciparum negative. Her Vidal came to be positive. And then when she recovered on steroids, that's the gaze downstairs. So when we received her in the emergency, we thought it is falciparum. But falciparum can also give rise to opsoclonus. That's for sure. There it is. You're seeing the jiggling of eyes? And I'll show you one beautiful slide of opsoclonus. This is the most famous slide in neuro-ophthalmology. This child must have taught a generation of neuro-ophthalmologists, or maybe multiple generations. This slide has been going around since 1952, right? And the nurse is missing on this side. I don't know what happened. The child had a neuroblastoma, that's for sure. It's multi-axial saccadomania. So that's, I think that should be okay. This is Japanese encephalitis, and this is the last slide. Now, in this slide, I'm showing you something which we all get to see in the wards if a patient is sick. These are horizontal roving eye movements. Now, a common question which is put to us is, please look whether the brainstem is involved or not. If you are having horizontal roving eye movements, your brainstem is intact. Please remember, this is a patient of hepatic encephalopathy having intact horizontal roving eye movements, right? And I thank you for your kind concentration. Thank you very much.
Thank you, Vivek, for an excellent presentation. Beautiful slides. And I'm sure everybody would have realized that it is always nice to hear what you talk. Beautifully presented, very nice slides. Thank you, Vivek, for excellent presentation.
Thank you.
See, we have just gone beyond time, and we'll have some question answers after some time, because Dr. Sudhir, our next speaker, is to go somewhere. So we'll have a talk by Dr. Sudhir Kothari, and then we go on for the question answers. Dr. Sudhir, please. Unmute self, Dr. Sudhir, unmute self. Not hearing.
Sir, please introduce Dr. Sudhir, sir.
Yes, Dr. Sudhir is head department of neurology at Pune Hospital. He's MD Medicine, DM Neurology, FRCP, London. He's a member of the Brainstem Society. He's fellow of the Royal College of Physicians. He's managing trustee of the Forum for Indian Neurology Education, or FINE, and he's an invited speaker on vertigo, headache, and epilepsy. He has got publications on dizziness and vertigo, on neuroaudiology, and he's co-authored a book, Blind to the Mind, on the role of mind in human illness. Dr. Sudhir Kothari, please. Can you unmute Dr. Sudhir, please?
Sir is unmuted, but sir,
Sir, you are not heard.
maybe
Dr. Sudhir, you're not being
increase your
heard.
voice, laptop voice or something. Sir, we can hear you.
Perhaps sir is not joined in with audio.
Hello.
Yeah, I think somebody has to tell him that I think he has not joined in with audio, correct?
No, he's joined with audio, but maybe he's on some device, maybe earphones or.
Okay. Now is it there?
Yeah. Now we are able to hear you.
Sorry. Okay. Something was wrong. Okay. Let me, after listening to Vivek's talk, it was a pleasure listening to him after such a long time. I'm going to very briefly go over why you should look at the eyes in dizzy patients. So I've got 20 minutes and I'm going to be very fast. So why should you look at the eyes? So basically, when somebody comes to you with vertigo, the main thing, the clue is given by the history. So you got to listen to the patient. But the most important thing is examining the eyes. You examine the eyes and they will give you the diagnosis, and you got to put it all together and make a diagnosis. So it is a combination of history and looking at the eyes which tells you. So let us see what are the main conditions. There are 4 ways neuropathological conditions, that is dizzy patients and patients with vertigo, will come to you. And I'm going to make it simple. There are essentially only 6 disorders coming in 4 different ways. So one is acute vestibular syndrome, where this is a patient who gets an attack of vertigo for the first time. And here you will be mainly dealing with 2 diagnoses, vestibular neuritis or a cerebellar infarct. 3/4 cases will be roughly vestibular neuritis and 1/4 will be a cerebellar infarct. Then you have the second syndrome, that is recurrent attacks of positional vertigo. Patient lies down, looks up, turns in bed, and he feels spinning for a minute or 2. And this is most of the time BPPV, but sometimes central. Then the third syndrome is recurrent attacks of spontaneous vertigo. It is not positional. So, for example, somebody sitting and listening to a talk like this and suddenly everything going round, that is an attack of spontaneous vertigo. And the most important cause is, of course, migraine. Many of these patients are wrongly diagnosed as Meniere's, which is much less common. And the important one which we don't want to miss is the transient ischemic attack. We'll come to that. And then the fourth syndrome is no attack really, but person continuously keep feeling all the time imbalance. Of course, all these patients say, I'm feeling dizzy, I'm getting chakkar, but actually he's not getting vertigo, he's feeling loss of balance. Okay, so let's come to the first syndrome. This is the acute vestibular syndrome. These patients have a first attack, they are very sick, often vomiting, they can't walk, and they will usually land up in the emergency department and not in your clinic. And the most important causes are these 2, vestibular neuritis, but you don't want to miss a cerebellar infarct. And here the eyes come in very important, much better than MRI or anything, and much faster. Within minutes you can tell, does this patient have a cerebellar infarct or does he have vestibular neuritis? So how do you tell that? You have to remember this hints, the head impulse, I'll show you what it is, the pattern of nystagmus. You've seen number of nystagmus just now, but we'll see which of those are important in stroke. And then test of skew. I will show you what is skew. So this is what the nystagmus should be in the first attack. If in a vestibular neuritis, if the nystagmus will always keep beating in one direction, whether the patient looks to the left, whether he looks to the right, the nystagmus direction will be the same. We'll just see that. Sometimes even unidirectional can be stroke, and therefore you need the other part of the hints examination. Any other nystagmus, if the nystagmus changes direction, if it is up beating, if it is down beating, it is torsional, any other nystagmus is not vestibular neuritis, it is mostly a stroke. So this is unidirectional. The nystagmus keeps beating to the left. Whichever way he is looking, it is beating towards the left. Remember, we talk about the fast component of nystagmus. So the nystagmus is just beating continuously towards the left. Okay, So this is direction changing nystagmus. This patient looks to the left, the nystagmus beats to the left. He looks to the right, it beats to the right slightly, but this is important. This is not vestibular neuritis, it's a stroke. For example, let's look at this patient, 82-year-old. His hypertensive and diabetic. He came with acute onset dizziness and oscillopsia. He felt everything was moving up and down. That is called oscillopsia. So his speech was normal. He had this vertical nystagmus, which we'll see, and his gait was slightly unsteady. Just give me half a second. Oh. Yeah, sorry. So he came with this acute onset history, and these were his eyes. If you see, he's got an upbeating nystagmus. And somebody thought he was vestibular neuritis, but he came to me and I said, this cannot be vestibular neuritis. The nystagmus is upbeating. So we asked, these were the tests already done. He had an old MRI, which was showing few chronic ischemic changes. They repeated the MRI at 48 hours to look for stroke, and still it was normal. And now he came to me. So I said, no, this still has to be a stroke. Repeat a scan at 72 hours. And the scan at 72 hours showed this small infarct in the pontomedullary area. So the important point is, in a posterior fossa stroke, even if you have a 3 Tesla MRI, it can be normal. You must do a scan at 72 hours. So it can be normal in small infarcts, posterior fossa or lacunar infarcts. Okay, then we come to the hints part, the head impulse test. This is a very important test. The vestibular system is the one which keeps your eyes on target. Dr. Lal showed you how the saccades and the pursuit movements are important for looking at an object and to keep it in target. But when you're looking at something and somebody gives you a jerk, it is your inner ear which sends immediately the message to the brain that your head has been turned by 30 degrees and your eyes are immediately turned by 30 degrees before you can think of it. So within seconds or microseconds, actually your eyes move and you should see that the eyes are on target. This is how we are doing the test. I'm asking the patient to look at the camera and I'm giving him a jerk to the left. You can see that his eyes keep looking at the camera. This is normal side. Now this is abnormal. See, his eyes have got dragged to that side and he has to make a catch-up saccade. He has to move his eyes and then look at the camera. So the left side, when I'm jerking towards the right, it is abnormal. So this is a head impulse test which is positive on the right. Of course, now to show it to you, I have done this video at slow motion. Actually, when we do it, this is how it looks. On the left, normal. On the left, normal. And on the right, abnormal. Right, abnormal. So you have to just give a tiny jerk, ask him to keep looking at you or your eyes, and this is what it is. Then we come to skew deviation. Normally, when you cover a person's eye, both eyes are looking at the same spot. So even if you cover one eye and keep moving back and forth, both eyes will be looking at the same spot, and so they will not move. But when somebody has skew deviation, one eye is looking up, one eye is down. So when you cover this, that one goes up. When you cover it, one. So look at the up and down movement. Every time I move, that one goes. The right one goes up, left one goes down. So the eyes, right is up and left is down. And this is in slow motion, again, same thing. So normal person, when you do this cover, uncover, the eyes will not move. If you find this, it's a normal sign. This means that there is skew deviation. So if you find skew deviation, if you find absence of head impulse, or if you find direction changing or vertical nystagmus, it is not vestibular neuritis. You must look for a stroke. Okay, that is about the first attack. Now we come to recurrent attacks of positional vertigo. By far, the most important is BPPV, but sometimes you can get caught out with central positional vertigo. So BPPV is the most common type of positional vertigo. You all know about it. It's probably the most common cause of recurrent vertigo in adults. The history can be unmistakable. The patient comes and says, doctor, when I turn in bed, when I look up, when I bend down, suddenly I feel dizzy for half a minute or so. Typically on turning in bed or getting up in bed, they may get this. So history alone is not enough. As I said, but once you have heard the history, you suspect it, but you have to provoke an attack and look at the positional vertigo. He will get vertigo, he will shout, and you should see the nystagmus. So look carefully at the eyes. You must look at the eyes. These patients often get so scared, they'll close their eyes, they'll not, they'll shout or scream. You have to make sure that you can see the eyes when you are provoking an attack. So this is one patient who's showing us. So he gets this typical upbeating torsional nystagmus on lying down. This is classical nystagmus of right posterior canal, BPPV. So it stopped in 15 seconds. Many times you will get just 1 or 2 beats. If the person can't do it himself, you do what is called the Dick-Solpike maneuver, head hanging maneuver. Let the patient's head hang down and see the nystagmus now. This lady will get downbeating nystagmus rather than the upbeating one. She's got a different type of BPPV. So after a latent period, now you see. After a few seconds, it starts. So this is again BPPV. And in the clinic, sometimes if you have problem with space, you can do what is called the Sidelines Test. If you don't have space enough to get the person's head hanging down, then you do this. Turn the head 45 degrees to the left and fall on the right. Turn the head to the right and fall on the left. So I'll show you how this is done. On the left, on the right ear, nothing. And when he lies on this side, you will see the nystagmus. Okay. These little beats of nystagmus are very important. You can cure such patients immediately within minutes. So this is the roll maneuver for lateral canal. In lateral canal, you ask the patient just to roll from one side to the other, and instead of upbeating or downbeating, you will get a horizontal nystagmus. So this is horizontal nystagmus. This was lateral canal, and in my clinic, we've got a number of these devices. We call them video frenzel, where the patient does not see anything. He sees dark before his eyes. And these are special infrared cameras. So you see the eyes enlarged and you can see the nystagmus very clearly. So this lady has now, you can see her eyes. She'll get an upbeating torsional nystagmus. You see that? So you can make like these devices make life. This lady had bilateral. She had on the right, but we checked the left side. On the left also she had. Okay. So she's got on both sides. Once you suspect this thing, we've got different types. You must do this Dick-Solpike, and this is another camera where we watch the thing in front, and you are seeing the eyes going up. You see the nystagmus, see very gross nystagmus, and then you do the maneuver for repositioning. I won't go. This is the 1 minute maneuver, I call it. So we are doing the test. We are looking at the nystagmus and then looking at the thing. We turn the patient. This is the Epley maneuver. When you have this camera, you can do the maneuver much better and properly. Okay, so I won't waste time in that. This another 35-year-old man, he got a peculiar history. 2 months ago, as he was lying in bed, his son fell on his head. And immediately the person got a severe attack of vertigo. And thereafter, he was getting attacks every now and then, just lasting for a minute or so. He showed 2 neurologists who tried repositioning and then gave him drugs. So when he came to me, he was still getting these attacks and he was taking flunarizine, and I did the video frenzel, and he had this lateral type of BPPV, horizontal. But when he lies on the right, you'll see the nystagmus beats towards the left. At rest, there is nothing. His eye movements are completely normal. When he lies down, see what happens. So he's lying on the right here, the nystagmus beats towards the left, and then he lies on the right. And what he had was this large tumor in the posterior fossa. So this is called apogeotropic. That means when he lies on the right ear, the nystagmus is beating to the left. When he lies on the left, it was beating to the right. And this was a cause of central positional vertigo. The child falling on his head probably just initially moved that thing and triggered the attack, but it was not the cause of this tumor, obviously. Another guy, 45-year-old with positional vertigo, he had 5 months weight loss, 2 months of positional vertigo, and again somebody tried repositioning. See, one thing you must remember, if somebody does a repositioning, within minutes, the attack must stop. If you require to give a vestibular suppressant after repositioning, means you have not done a repositioning. So this patient, he came to me, he looks to the right, he has nystagmus beating to the right. He looks to the left, he has nystagmus beating to the right. This is obviously not BPPV. BPPV, you have to get positional vertigo. He's getting gaze-evoked nystagmus. Therefore, we said this has to be a central cause, and this is what he had. He had multiple tuberculomas. There was one tuberculoma in the posterior fossa, and that was the one causing the positional nystagmus vertigo. We'll not go into this. Central positional vertigo, migraine is a common cause, but you have to think of tumor, like we saw, infarcts also can cause. Then we come to the third syndrome, when they get spontaneous attacks. Do I have 5 more minutes? Spontaneous attacks of vestibular syndrome. So these patients come with attacks of vertigo which are not positional. And most important thing which you should not miss is a TIA. And then, of course, most common one is migraine, and rarely there is Meniere's. We'll not spend too much time on that. The important thing is here you have only history. When the patient comes, he says, I get attacks, but they are at home. So when he comes to you, everything, examination is normal. Such patients, you tell them that when you get an attack, take a recording of your eyes, show them how to record the eyes properly, and get that video. We've diagnosed many patients with the video that they bring to us. And I'm trying to get a portable video Frenzel, which you give to the patient, he puts it on, records it, and brings it back. Such devices are available, but they're too expensive as of now. So this was a 60-year-old guy who came with recurrent attacks of vertigo lasting 5 minutes. Luckily, he got an attack in the hospital. And you could see this, he got a gaze-evoked nystagmus beating to either side. This was obviously not, it went off in 5 minutes. This was not Meniere's the way it was, and therefore we asked for the MRI, and he had this basilar stenosis with small infarct in the cerebellum and the pons. So you should not miss a TIA, it's very important. Then we come to the last syndrome, this patients who come with imbalance. So such patients, now you have to think of vestibular failure, extrapyramidal disorder, cerebellar ataxia, PSP like Dr. Lal showed you, peripheral neuropathy, and many other things can come with only imbalance, but not vertigo. So this is one girl with 1 month of dizziness. She looks to the left. You can see the nystagmus in the left eye, and the right eye is not adducting properly. So this is internuclear ophthalmoplegia. Another girl with similar internuclear, but now bilateral. She looks to the left, right eye is not coming in. She looks to the right, the left eye is moving less, and there's nystagmus on both eyes. So both these girls have multiple sclerosis. When you have internuclear ophthalmoplegia in young persons, always think of multiple sclerosis. This was an ENT surgeon secretary. She had been complaining of dizziness to him for 5 years, and she had hearing loss. And this was a nystagmus. See the nystagmus, see what happens when it beats. So essentially, when she looks to the left, nystagmus beats to the left. She looks to the right, it beats to the right, but it is not symmetrical. On looking to the right, it is fine and faster. On looking to the left, it is slower. And this is called Brunn's nystagmus. This is typical of cerebellopontine tumor. This is another boy with a Brunn's. See his nystagmus also. It is asymmetric. So it's finer on the right and more coarse on the left. And what they had was this large. That one had a CP angle acoustic, and this one has an epidermoid. Another woman with this peculiar nystagmus. This is called convergence retraction nystagmus. The way to see it is look at her nose. When you look at her nose and when she looks up, you'll see both eyes are moving towards her nose. So this is convergence nystagmus. And this lady was having dizziness for 2-3 months and a little imbalance. And when you get this sign, you must think of a lesion at the back of the midbrain. So she had a Parinor syndrome due to a pinealoma. Another lady with peculiar dizziness, breathlessness, numbness in the head on coughing. When you have symptoms on coughing, always think of a posterior fossa lesion at the craniovertebral junction. She has got this downbeating nystagmus, even at rest, more when she looks up, and also when she's looking down and out. So you all know she has got a Arnold-Chiari malformation, and there's also a syringomyelia. Another young boy with 1 month of unsteadiness while walking. He looks to the right, nystagmus to the right. And he looks to the left, nystagmus to the left. So this cannot be an ear problem. This has to be CNS. This is going on for a month, and this is what he had, a large pontine glioma. So always pay attention to the eyes. They are very important. And let's come to the take home. The history is crucial, of course. It gives you pointers what to look for, but the eyes will tell the diagnosis. The eyes confirm the diagnosis. You got to look closely. It can be just 1 or 2 beats. The patient might close his eyes, or you may feel, why trouble him if he's getting vertigo, let him not get, So, but you have to induce an attack and see everything. Don't miss BPPV is extremely treatable. In 5 minutes, you can cure the patient. Don't miss a stroke. It's dangerous. And various central causes can present themselves with their eye signs, and you can get an idea about what they are. Thank you.
Thank you, Dr. Sudhir. Beautiful talk. Very nice. I'm sorry we delayed you. Okay. The next talk is going to be by Dr. Sujit.
Thank you, sir. I hope I'm audible.
Yes, you are audible. Dr. Sujit is a consultant neurologist and epileptologist at Apollo Hospital, Bengaluru. He's DM from PGI, our alumni. His area of interests are EEG, DBS, stroke, neurology, and refractory epilepsy. Dr. Sujit, please.
Sir. There are the slides shared, sir. I'll just go to the slideshow mode. Good evening, sir. Good evening, everyone. I'll start with William Shakespeare's quote, "The eyes are the windows of the soul." So we always have to look at the eyes. I've had the privilege of great teachers. Professor Prabhakar was my HOD, and I was initiated into neuro-ophthalmology by Professor Lal. And since the last 8 years, we run a neuro-ophthalmology clinic also at Narayana Eye Hospital in Bangalore. So every day when I see my patients, I remember my teachers. So as Dr. Lal has already told, eye movement disorders have got, I'm going to be talking today about sick patients with eye movement disorders, or eye movement disorders, what we see in the ICU. So there are disorders involving the afferent pathway, but this is an eye movement disorder. So we'll stick to the efferent pathway. So my talk is going to encompass only case presentations, what we have seen routinely in the ward and in the clinic. So the first case was a 64-year-old lady who presented with a history of acute onset weakness of left half of the body with altered sensorium following a fall. Clinical examination revealed she had a left hemiplegia with, she was localizing pain in the right upper limb and lower limb. On neuro-ophthalmic examination, what we noticed was there was a horizontal gaze palsy to the right. So this is because there is involvement of the right frontal eye field. And so the conjugate gaze movement towards the left does not occur. This is what the patient had, with a lot of edema in the frontal lobe as well. Case number 2 was a 46-year-old lady who presented with a history of weakness of right half of the body associated with altered sensorium. She had right hemiplegia, was drowsy, was not localizing pain. And this is what we saw on neuro-ophthalmic examination. As you can see, there's a very fast, rapid eye movement upwards and a slow movement downwards. This is a classical ocular dipping. Ocular dipping does not have any clear-cut localization and can come from the brainstem. It can also be seen in hydrocephalus and various other metabolic encephalopathies as well. This is what the MRI showed an extensive infarction involving the posterior circulation. Another lady, again 45-year-old hypertensive, presented with an acute history of altered sensorium since 1 day. She had a right hemiplegia, and this is what we saw. As you can see here, this is a monoocular ocular dipping. And as you can see, there's a fast component upwards and a slower component downwards. It is involving only one eye. And this is what we saw. There was a focal hemorrhage involving the pons, involving the left half of the pons, which was extending up into the midbrain. Coming to case number 4, this was again a 45-year-old male. Uncannily, all of them seem to be young stroke patients. Presented with a history of acute onset altered sensorium since the last 12 hours. Patient was drowsy and quadriplegic. And this is what we saw on neuro-ophthalmic examination. As you can see, there's a faster movement downwards, followed by a slow movement upwards. So this is the classical ocular bobbing that was described by Fisher in 1961. And this is the MRI of the patient showing an infarction extending right from the medulla up to the pons. A 55-year-old lady, this was a patient whom we saw in our outpatient clinic, although she turned out to be sick later. She presented with an acute history of decreased vision to the left, like a hemianopia, and also episodes of eye and head deviation to the left since the last 2 hours. So this is what we saw. As you can see, there's a rapid eye movement to the left, like a nystagmoid movement, and there's a head turning also to the left. What this lady had was a posterior head region seizure, focal seizure, which was happening, involving the parietal eye field and the TPO. The MRI showed a hyperintensity in the right PCA territory, but you can see it was not dark on ADC. And further on the MRI, we see a hypointensity in flare. Now, before the MRI, of course, we knew the diagnosis because the patient's sugar was 700. This is a classical presentation of hyperglycemia, something that we can miss and conclude that it's a stroke sometimes. Coming to case number 6, there was a 70-year-old male presented with a history of acute onset headache and loss of consciousness since 1 day duration. Clinical examination revealed left hemiplegia. We have discussed this in the previous talks, and over a period of next 6 hours, he developed a dilatation of the right pupil. This is a classical Hutchison sign, which Professor Suresh Nair described. As you can see, the right eye pupil is dilated, and the left eye is not. So this patient had a large right MCA infarct and had to be taken up for hemicraniectomy. What we noticed was because of the uncal herniation, there was a compression of the pupillodilator fibers of the right third nerve, producing the Hutchison's pupil. This was another lady who presented to us with a history of headache and unsteadiness, this time since 1 month. Clinical examination revealed gait ataxia. She had bilateral disc edema, and this is what we saw. Professor Kothari has actually shared a similar video. As you can see, on upward gaze, there is both a convergence of the eyeball, of the eyes, and there's a retraction, global retraction. This is a classical convergence retraction nystagmus. This lady had an acute obstructive hydrocephalus and had to undergo a third ventriculostomy, endoscopic, and after that she completely recovered. I have the subsequent video where she's completely recovered. In the interest of time, I'm not showing it. We have a couple of cases more. A 75-year-old lady came, this again, to our neuro-ophthalmology clinic with an acute onset headache and drooping of left eyelid since 1 day. Clinical examination revealed a third nerve palsy with pupillary involvement. When we did a scan, we found there was an SAH with left PCOM aneurysm. I don't have a video of her palsy, we just have a photograph. And this was a PCOM aneurysm, which was subsequently coiled. And she completely recovered. This was a more recent case that we saw. I mean, this is last year. A 50-year-old male presented with a history of fever since 1 day and altered sensorium, inability to open both eyes since 1 day. Clinical examination, he was conscious, alert, and oriented. There were no motor deficits. But this is what we saw. Patient had bilateral ptosis and complete ophthalmoplegia. He was unable to move the eyes in any direction. So there was no movement to the right, left, up or down, and there was no pupillary reaction as well. So the patient had, although this is showing a diffusion restriction, it turned out to be cerebritis, secondary to mucor. As you can see, the sinuses are completely involved, the ethmoid also, and you can see here, there is a complete mucor. This patient had COVID, was admitted with COVID, was a diabetic, and developed severe bilateral rhino-orbitocerebral mucor. Unfortunately, the patient succumbed despite treatment. So mucor can sometimes present bilaterally with severe orbital involvement and complete ophthalmoplegia. This was another lady who presented with a history of headache since 1 week and closure of the right eye since 3 days. She had a complete third and sixth nerve paresis. Again, here we don't have her video, and she had an aneurysm in the cavernous portion of the internal carotid artery, and a flow diverter was deployed, and she recovered completely. As you can see, the aneurysm is closed and she recovered completely. So this is our neurosciences team and our neuro-ophthalm team. And I'll finally end with Winston Churchill's famous words that success is not final, failure is not fatal. However, it is the courage to continue that counts. Thank you.
Thank you, Dr. Sujit, for a very nice presentation. I think the brain doesn't know with the other way around. Eyes won't see which the brain doesn't know. So you started looking for them and you have started finding things. Very good. Very well done.
Thank you, sir.
With this, the talks are over. I think I hand over to the digital team. I don't know whether any questions, answers are there or not. Dr. Dwarkanath, your team, please.
No, sir. It was a wonderful presentation and I really enjoyed the videos. And in case you did not know, I also did my MS in PGI almost 25 years back. So
very nice, very nice.
So nice to see all the PGI people, sir. And
At
the
least
talks were really good. The videos demonstration was excellent, and it was a pleasure seeing the videos. It's a great educational experience also. Really nice.
I think we are grateful to all the 4 speakers. I can tell you, everyone who has been listening to and looking at the talk today, they would be enlightened and they would have known and learned something new. Beautifully done. And Lal's slides are always perfect. I think this is a nice way he does it. Thank you very much.
Thank you.
Thank you, sir.
Thank you, sir. Thank you for the compliment. Thank you very much. I really enjoyed the session.
Okay. Thank you. Thank you, everybody.
Bye.
And anyhow, and just a message that these YouTube videos will be available on link so that people can still access them and learn also in the future if they want to refer to all
so
these.
Dwarkanath, you were saying you've been in PGI 25 years ago. Which department were you in?
I did my MS General Surgery in PGI, sir.
So that's okay. If I missed you, it's okay because we hardly are in contact with surgeons.
When Dr. Kataria and Dr. Bose and
what a name, Kataria. Cats.
I had come to PGI and